So ASH took a very active interest in developing guidelines for older patients with AML, and this was a very unique sort of guidelines. Usually guidelines are made by a team of experts, a lot of maybe personal sort of the review data, personal opinions and experience. And what these guidelines did is got a group of people being part of this panel. And that included not just leukemia doctors, but statisticians, epidemiologists, and also patients, because we wanted to incorporate sort of patient goals into our guidelines. We wanted to really understand, are we being true to the patient goals that are important to them? And this followed a very rigorous sort of statistical meta-analysis where all the data were reviewed, and there was McMaster University had created a very rigorous sort of guideline, a statistical data, putting all of this together. The first thing that the guidelines panel did was to answer a set of very difficult questions. There are questions that there's ample data, no controversies at all, but there are questions in older patients with AML that are just very difficult to answer. And we purposefully chose these questions, and that took like a long time because we wanted to prioritize sort of the questions. Once the questions were asked, the rest of the sort of process evolved. And there were many questions that are important. For example, what should older patients with leukemia be treated? What about palliative care? Should transfusions be given in palliative care? Is lower intensity better than intensive chemotherapy in older patients with AML? What about once you're in remission? What happens after? What is the recommendation? What is the recommendation based on the data? These are very, very important clinical questions that we discuss with patients as clinicians right from the beginning, except that there's no, unified data or answers to these questions. So there were several topics selected. Part of this sort of discussion at this ASH was to update the first of all, to reiterate the guidelines recommendation, and also to update new data, because these guidelines may evolve over time based on new data coming in. So I had discussed several, people talked about this. I discussed on So I Am in Remission. Now what? Going over sort of the post-remission therapy, the newer approvals for maintenance therapy in older patients, where we now have options for maintenance therapy, including FLT3 inhibitors, oral azacitidine. We talked about several post-remission therapies in the post-transplant setting, where several agents are currently in clinical trials. But the idea of sort of this session was to go over these guidelines, update sort of the new data, and we hope that in the future these guidelines would be officially sort of updated based on the new available data.